Embryology and Surgical Anatomy of the Auricle. Chapter 1. Embryology. The embryology of the auricle is inseparably connected with the development of the lateral head and neck region and the middle ear. The initial development of the inner ear, on the other hand, is largely independent of these. In the first 3 to 4 weeks, the development of the head is determined by two areas, the frontal head organizer and the posterolateral head organizer. Later, the forehead, the nose, the philtrum, and the intermaxillary bone will develop from the frontal head organizer. The posterolateral head organizer induces the development of the branchial arches, out of which the ear will develop. The area of fusion of both these organization centers is an embryological storm zone, where many defects may arise, such as the relatively frequent cleft lip or cleft palate. The ear develops from the region of the branchial arches. After the formation of the primitive pharynx in the first weeks of embryologic development, a series of lateral sacs, called pharyngeal pouches, appear in the 4th and 5th weeks. The initially shallow recesses push themselves further and further into the mesenchyme. At the same time, they narrow increasingly so that they are finally connected to the lumen of the primitive pharynx by means of slit-shaped openings. Parallel to the development of the pharyngeal pouches, 4 recesses called branchial clefts appear on the surface of the embryo. They also push deeply into the mesenchyme until they finally push against the pharyngeal pouches. During this development, the tissue of the mesenchyme is divided into segments between the individual pharyngeal pouches and branchial clefts. The individual mesenchyme bulges are called branchial arches. By the end of the 5th week of development, 5 branchial arches can be discerned. In the following weeks, a cartilaginous skeleton, muscles, an artery, and a nerve develop in each of the arches. In the course of further development, this segmentation disappears. Many deformities, however, can be traced back to disturbances at this stage in the development of the branchial arch system. The first branchial arch, also known as the mandibular arch, is responsible for the development of the lower jaw, malleus and incus, the mastication muscles, and the mandibular nerve. The second branchial arch, which is also called the hyoid arch, leads to the formation of the stapes, the styloid process, the stylohyoid ligament, and parts of the hyoids. In addition, the facial nerve and all of the muscles supplied by it. For example, the stapedius muscle, the stylohyoid muscle, the anterior belly of the digastric, and the mimetic facial muscles are derived from the second branchial arch. In the 6th week of development, 6 mesenchymal thickenings in the form of small hillocks appear on the dorsal margins of the first and second branchial arches, 3 on the mandibular arch, and 3 on the hyoid. Located between the mandibular and hyoid arches is the first branchial groove, which pushes inwards to form the external auditory meatus. In the following weeks, the auricle develops from the 6 hillocks of the first and second branchial arches. A dominant role in this process is played by the hillocks of the second branchial arch, out of which the lobule, the antehelix, and the dorsocaudal part of the helix are formed. The tragus develops mainly from the first hillock of the first branchial arch. Whether the other hillocks of the first branchial arch take part in the formation of the ventrocranial part of the helix or whether it also evolves from the second branchial arch is still a matter of dispute. Because the process of fusion is relatively complicated, there is a great variability in the form of the auricle. There are no hard and fast borders separating normal from abnormal development. For clinical and surgical purposes, the more pragmatic classification is the Weirder's classification. The Weirder's classification has 3 degrees of dysplasia. In the first degree dysplasia, most structures of the normal auricle are recognized, and surgically reconstruction normally does not require the use of additional skin or cartilage. In second-degree dysplasia, only some structures of a normal auricle are recognizable and surgically requires partial reconstruction with the use of some additional skin and cartilage. In third-degree dysplasia, none of the structures of a normal auricle are recognizable, hence a total surgical reconstruction is required with the use of skin and large amounts of cartilage. During its development, the auricle shifts its position in relation to the jaw from ventrocaudal to dorsocranial. This explains why abnormally formed ears are frequently positioned too far anterior and caudal. As a rule, the more serious the malformation of the auricle and the other organs of the first 2 branchial arches, the further the rudiment of the auricle is shifted in an anterior and caudal direction. In the 3rd to the 6th month of development, the auricle makes further progress in the formation of its typical relief structure. The helix curls, the antehelix folds up, and the auricle as a whole detaches itself from the head. Disturbances occurring in this phase of development can lead to any of a number of minor deformities, including protruding ears. All disturbances in embryologic development is not only the degree of damage but also the point in time when it occurs that is decisive in determining the type and character of auricular deformity. These relationships have been summarized by Weirder in a modified version of Lieber's model. According to this model, anotia, complete absence of the auricle, and severe microtia come about in the first 7 weeks post-conception and minor dysplasias between the 7th and 8th weeks. Disorders occurring later only causes minor degrees of morphological variation. Chapter 2. Surgical Anatomy. Although in humans, the auricle plays only a minor role in hearing ability, it is an artistic work of nature with its individual eminences, depressions, and also an important factor in a person's aesthetic appearance. Reconstruction of the auricle as in cases of congenital anomaly or partial or total ear loss requires exact knowledge not only of its position and inclination relative to the head but also of its relief structure. Various measurements regarding the position of the auricle have been published by Farkas and others. In our own computer-assisted study of over 1,000 healthy ears, we have been able to supplement these measurements and determine 50 anthropometric parameters of auricle position and relief in relation to age and body height. In the following we describe some of the most important parameters needed for auricle surgery. The position of the auricle. In order to determine the position of the auricle on the head, it is necessary to use a reference line that is as independent as possible from deformations in the area of the auricle. Suited for this purpose is a vertical profile line that runs through the glabella and the furthest anterior point of the relaxed upper lip. Perpendicular to it, the horizontal profile line can be constructed as the second axis of a coordinate system. The horizontal profile line intersects the well-known Frankfurt horizontal plane at an angle of approximately 2 degrees, although the latter cannot be determined in cases of major malformations or total loss of the auricle. Other important parameters used for measuring the position of the auricle are the furthest posterior point of the skull, the occiput, the highest point of the skull, the vertex, and the axis of the auricle in relation to the facial profile line. The auricle from a lateral perspective. The horizontal position of the auricle. The horizontal position of the auricle from a lateral perspective can be calculated from the distance of the vertical profile line to the trajan, the distance of the trajan to the occiput, and their relation to one another. In adults, the distance from the vertical profile line to the trajan averages 102 mm, from the trajan to the occiput, 93 mm, and their ratio is 93%. Vertical position of the auricle. The vertical position of the auricle in its lateral perspective is determined by the distance of the trajan to the vertex. Because the vertex, the highest point of the skull, can vary in its exact location, sometimes being further anterior or posterior, it is less advisable to determine the absolute distance from the trajan to the vertex. One should instead use the distance from the trajan to a horizontal profile line that runs through the vertex. In adults, this distance averages 137 mm. Axis of the auricle. The axis of the auricle, i.e. the direction of its greatest diameter, intersects the vertical profile line at an angle averaging 10 plus or minus 4 degrees. This value remains almost constant during a person's lifetime. The axis of the auricle and the nose forms an angle of approximately 18 degrees, which is also independent of age or sex. In ear reconstructions, both of these angles should be taken into consideration in order to obtain aesthetically optimal results. The auricle from a frontal perspective. In judging the auricle from a frontal perspective, many studies have used measurements of the distance of the auricle or its angle to the outside surface of the mastoid. For an aesthetic impression of the auricle, however, this measurement is less important than its visible width or surface is viewed frontally. Whereas the surface is viewed frontally can only be calculated using computer-aided methods, the width can be estimated by direct observation of patients. For this reason, it is better suited for surgical planning. On the basis of data obtained in our own studies, we determined an average auricular width as projected onto a horizontal line connecting both pupils of 20 plus or minus 4 mm. This value decreases slightly from 21 to 19 mm during a person's lifetime. Chapter 3. The relief structure of the auricle. Individual structural features of the auricle. Detailed anatomic knowledge concerning the shapes of the following auricular prominences is necessary when performing corrective surgery. The helix is the outer frame of the auricle. It is lightly grooved like a rain gutter and beginning at the cavum conchae forms an arch that runs in a spiral that forms a 3/4 circle until it finally merges with the lobule. The antihelix is an arch-shaped supporting structure for the helix, with its two legs, the crus superior and the crus inferior. It begins below the anterior, upper part of the helix. At its other end, the antihelix forms a small thickening, the antitragus, and then merges with the lobule next to the helix. The tragus lies like a small windbreak diagonally at the entrance to the auditory canal. Located between these three prominences are the following depressions. The cavum conchae is framed by the antihelix and the auditory canal. The fossa triangularis, as its name implies, is a triangular depression between the crus superior, the crus inferior, and the helix. The scapa forms a furrow between the helix and the antihelix. Its cranial end is shallow and wide, and its caudal end rather narrow. All of the above-named auricular structures receive their shape from the underlying supporting structures of elastic cartilage covered with skin and a thin layer of subcutaneous tissue. The lobule, on the other hand, has no cartilaginous supporting structure. Instead, it consists of a relatively thick layer of subcutaneous fatty connective tissue. Morphometry of the auricle. Of the many parameters provided by morphometry of the auricle and its relief structure, the following values are clinically the most relevant. The maximum length of the auricle in adults averages at 63 mm. The maximum width of the auricle is calculated as the greatest diameter perpendicular to the axis of the ear. It measures 35 mm and, like the length of the auricle, correlates to the body height. The ear base is the part of the pinna where it joins the cheek. It extends from the attachment of the helix to the incisure on the anterior edge of the lobule and measures 43 mm. The form of the lobule can be described by measuring its corresponding length and width. The length is measured from the intertragic incisure to the inferior edge of the lobule, and the width from the inferior end of the ear base to the caudal end of the scapa. The mean values of length and width are 18 and 14 mm, respectively. Their ratio goes up slightly with increased body height and averages 1.45 for an adult with a height of 170 cm. Individual variations in lobule width are particularly marked, with a standard deviation of 5 mm. The relative sizes of the individual relief structures can be described by an anthropometric division of the auricle into three parts that are measured vertically along the long axis of the ear. The upper third extends from the upper edge of the helix to the beginning of the cavum conchae. Its mean length, 18 mm, corresponds to 29% of the total ear. The middle third extends caudally to the antitragus and averages 23 mm, roughly 37% of the ear's length. The lower third comprises the distance from the antitragus to the lower edge of the lobule and averages 22 mm, roughly 35% of the ear's length. The ratio of these three parts to one another remains for the most part constant. Muscles, arteries, and nerves of the auricle. While some animals have muscles that can adjust the position of their ears in the direction of oncoming sounds, the ear muscles in humans have neither a functional nor an aesthetic purpose. They are phylogenetic vestiges of earlier developmental stages and will only be mentioned here briefly. The anterior auricular muscle runs from the temporalis fascia to the anterior edge of the helix. It draws the ear forward. The superior auricular muscle originates in the epicranial aponeurosis and draws the ear in a cranial direction. The posterior auricular muscle runs from the dorsal to the posterior surface of the auricle. The blood supply is carried to the external ear over a dense vascular network fed by the superficial temporal artery and branches of the posterior auricular artery. The sensory supply of the auricle is carried from its anterior side via the auricular temporal nerve to the trigeminal nerve and from its dorso-caudal portion via the great auricular nerve, as well as from its dorsocranial part via the lesser occipital nerve to the cervical plexus, C2 and C3.